Control and Prevention Office. And as planned today, we have the first session in exchanging the expertise, and this activity is supported by UCSF in collaboration with VADB in Vietnam. And as you all know, UCSF is a very experienced partner in providing technical assistance and training for HIV partners around the world. And I hope that through the series of exchange and discussion, we can learn a lot of real and practical experience and knowledge to support our real work. And before we start the session, I'd like to ask all of the participants to change your account's name on Zoom. And in your default name, there should be your real name and your institution. Thank you. All right. And before Dr. Ali starts his presentation, I'd like to invite Dr. Kwok, the head of the Strategic Information Committee of USCDC, to join us and share a few thoughts. Thank you, Trang. Good morning, ladies and gentlemen. So once again, on behalf of the Technical Working Group of USCDC and VADP, we would like to express our sincere thanks to all of your participation and your time for joining us today. And today, we welcome you to join us in the session, one of the discussion between UCSF team with VADP and the Vietnamese team. And in this technical meeting, we are very thankful and grateful to have Dr. Ali joining us and sharing with us about this topic. There's some background noise somewhere else. I think one of the participants is turning on the speaker. So let me continue. So also I want to strongly support as well as to express my sincere thanks to Dr. Nhàn, Dr. Mạnh, and the technical team at VADP and the technical expertise from UCSF team and the team from USCDC for all of the effort to prepare for this session. Thank you for preparing all of the slides, content, and all of the follow-up discussion to make this session happen. Once again, thank you all for your time, and I hope that we will have an interesting, productive, and practical session. Thank you. Sir, I think you're good to start now. Yeah.
Awesome.
Oh, Miss Trang, continue. Yes. Next, I'd like to invite Dr. Ali to start his talk. Your turn, sir.
Awesome. Thank you so much again for the nice introduction. It's really a pleasure to work with Vietnam, and then again in this activity, continuing our collaboration with VIDP, Vietnam CDC, and the CDC work in Vietnam. Today is one of the three topics that we're going to cover in 3 weeks. This is a topic about survival analysis with time-varying covariates, and we're going to talk about some advances in extended Cox proportional hazard models. We have some examples, and I'm going to talk about this topic. We have time to also answer to your questions. These are the learning objectives for today. There's going to be a quick refresher on the survival analysis. What are the basics? Why we should think about time-varying covariates, when it's useful, what is the extended Cox model to assess the time-varying covariates effects on the outcomes, and then how we can use data and R and then be able to read and interpret the output for this analysis using 2 real studies, one from a methadone study and one from the heart transplant study. So there would be 2 practical examples at the end. We're going to review the results together. I would like to start to introduce with myself. So my name is Ali Mirzazadeh. I'm an epidemiologist. I'm a faculty associate professor here at UCSF. I born in Iran, and I did my medical school PhD and MPH quite a long time ago, but have been at UCSF since 2012. And I'm also working with the Global Health PhD program here as an acting director. My research focuses on HIV, hard-to-reach populations, and then medical records. So my favorite activity is biking, and I supported HIV programs by biking from San Francisco to LA 9 times. So that's also my activity beside using the data and survivor analysis. I also love Vietnam. I have the pleasure to work with many of you in institution over the past 6 years. So this is a proof that I was going to a workshop in Da Nang um, last summer, and it was raining in the morning, and I had to use this plastic cover when I'm going to the workshop. So I really appreciate the collaboration and the country and everything, the culture people. Um, to start about survival, so survival is a data that people can enter to the study at any time. They become at risk for the outcome, and they follow for the death here as an outcome. And during the follow-up, they can end to have the outcome, or they can be censored during the follow-up. The censor could be if they lost the follow-up, we don't know. We have the last visit of them. We meet them at the clinic, but we don't know what happened to them after the last visit. Or it could be like the study ended. So we had to stop the study because of the end of the study funding. So we don't know. We don't have a chance to follow them. The survival analysis include those lost to follow-up or censorship into the analysis to produce reliable outcomes. This is an example from data from San Francisco. We're looking at the time from AIDS diagnosis to death, losing the data from 2012 to 2020. And you have subgroups of the people. At the time of diagnosis, we had people who are men who have sex with men, people who inject drugs, MSM, who inject drugs, and heterosexual, who got the infection through heterosexual. And what do you see here? There are three lines. This is a survival plot. At the time they get the diagnosed with the AIDS, everyone is surviving, like because we find them. So they start at 100% survival at the beginning. And during the months of the follow-up after the AIDS diagnosis, you can see the survival change. So some of them found to be dead during the follow-up. And you can see there are differences in the survival, like how long they survive. So my question for you, which group had a better survival here? So the one that is staying close to the 100%, right? So if you're looking at the red line, men who have sex with men, they survive longer after the AIDS diagnosis. And on who survive less during the follow-up? The people who drop the survival, the green line, people who inject drugs. So it gives you a sense like who is dying at a higher speed and who is dying at a lower speed after the AIDS diagnosis. But if we want to test if those lines are different, statistically different, the curve of survival is different, we have two options here. We can use a long rank test, which is giving more weights to people who survive at the end versus dying at the end. And then we have Wilcoxon rank test, which is give more weights to lost people at the beginning of the survival follow-up. Most of the time, it's really a log rank test, I would say, is more popular. So if I put the log rank test here, and I'll give you the p-value for that one, you're going to conclude the lines that are here from my study, they are statistically differences here. The difference between men who have sex with men, the survival is significantly higher than the other group. I can't tell which group is better, but I can tell you those groups are different according to the survival to death after AIDS diagnosis. You can also report the effect of the covariates or the predictors on the outcome using the multivariate analysis. So if your outcome, for example, is continuous, let's say your outcome is like screening time. How much screen, how many times per day do you watch screen? If that is your outcome, you are looking at the linear regression analysis, and the beta coefficient in the model is going to report how much differences between, for example, girls and boys. What is the mean difference between the screen time between boys and girls? And beta coefficient for the gender will tell you that one. If your outcome is binary, let's say if people, for example, have depression or they don't have depression. And then you have, again, boys and girls. If you put it in the logistic regression, which is the analysis for the binary outcome, the beta coefficient is going to tell you about the odds ratio. And the odds ratio could be high or it could be low, and it will tell you if boys are have a higher odds for the outcome versus girls. In the survival analysis, we are going to use the Cox regression model, and the hazard ratio is the beta coefficient in the model. And that is something we're going to talk about today. So this is an example. So the hazard ratio here is presenting what is the effect of sex on mortality. We are talking about, for example, here, the AIDS mortality here. And what do you see in this coefficient in this table? The beta coefficient for sex is for men because sex is coded as 1 and 0, and the coefficient is 0.3. This is the coefficient in the Cox regression, right? If you want to change it to the hazard ratio, you need to exponentiate that one. So the exponentiate of that one is equal to 1.39. We call it the hazard ratio. And how we're going to read this is going to be men have approximately 39% higher hazard compared to women here in this study. The p-value for that one is also presented in this table, 0.023, and that is suggesting that men have a higher hazard for the mortality in this study compared to women, and that is statistically significant. You can also exponentiate the coefficient, lower limit and upper limit of the coefficient, and you will get the hazard ratio, lower limit and upper limit bound. And as you can see here, the lower limit doesn't touch or reach to the 1, which is the equal between the two groups. So it's also suggesting there is a significantly higher hazard for the mortality for men versus women. If you want to write down the hazard model in a formula, so that will be the hazard of mortality given the sex is going to be a baseline hazard. We're going to talk about that. And the coefficient for sex, which is come as an exponential formula here. And you can also replace the beta coefficient here. So this is the full scope of the equation for the Cox regression. But what is hazard? So hazard function. This is something to know and talk about. So here on this graph on the left, we are talking about the mortality as people age. So this is a normal aging. When you are young, your hazard for mortality is almost flat. It's not going up. And as you age, your risk for dying is going up. So the hazard of death is going up exponentially as you age. Here we're looking at the hazard for death after the heart attack. So if you have AMI, your risk of dying is very high right at the AMI time or right after a few days. There's a high risk for dying or the hazard is high. But as the days goes past from the AMI or the myocardial infarction, your risk of dying from that event is going to reduce over time. So over time, your hazard for dying going to reduce in this outcome. Here we're looking at heart transplant or heart bypass, the coronary CABG. So people who receive this bypass, coronary bypass, there is a higher risk at the beginning or right after the surgery. And then as they recovered from the bypass, their survival goes better, the hazard of dying goes down. But over time, they build up complication. They coronary artery disease, they have more blocks and then more coronary being infected over time. And then what happened here, again, is pick up the hazard after a few days, 5 years, after 5 years, 10 years, if they do not really prevent the stuff from getting more coronary artery disease, it's again picking up and then it's going to be high again. Below, I'm talking about the hazard in two groups. So if one group has a baseline hazard and the other group over time has the same ratio for the hazard, this is the hazard ratio between the two groups is the same. Here, here we're talking about the hazard ratio in group 1 versus group 2 is also constant over time. The hazard increase in both, but the ratio of the hazard in group 1, blue versus group black at the baseline is the same. In this case, also at any time of follow-up, when you're seeing at this hazard shape, you can see the hazard ratio between the blue and the black, which is the two groups in my study, they remain constant. So that if the hazard ratios remain constant, I don't need to say hazard at any time. At any time, hazard is going to be only fixed and one ratio. And that is important. So that makes things simpler to explain. So let me go back to the principle. When we're talking about the Cox proportional hazard model, we are assuming three things. One is the people in the study, they are not clustered. It's one observation, one study. These are not families. These are not patients from a hospital. These are not patients who went to a surgery by one physician. So they are not clustered. They are independent from each other. Randomly, people selected for the study. But if they are dependent, if there is any cluster, we need to do the right analysis. Another assumption for the Cox proportional hazard is independent censoring. So people who lost to follow-up versus people who stay in the study for a longer time. We don't want to have an association between loss to follow-up and that loss to follow-up is associated because they had the outcome, because they had a higher risk for the outcome, because the risk factor is different. So people who censored or lost to follow-up, it should not be associated, this censorship, to their risk factors and also their outcome. So this is an important assumption here. There are some ways to check that one, but I wanted to highlight independent censoring is an important thing for survival analysis. Another thing here is the Cox. We are using Cox proportional hazard. So the Cox proportional hazard makes things simple, but there's a big assumption here. If the hazard or the risk of the outcome is between the two groups is parallel and the ratio is constant over time, we are using this Cox proportional hazard. If the hazard cross over time or is becoming not as a fixed ratio, then we have to use a different model, which is a non-proportional Cox hazard, which we are going to talk today about that. So this is the advantages of using Cox model. So you can use the Cox model to assess what is the effect of a continuous predictor. So you can assess what is the age at diagnosis effect on the outcome. You can assess the binary predictor on the outcome. So you can have group 1 men, group 2 female. You can also assess the categorical predictor. So for example, if the transmission routes for HIV includes four groups, MSM, PWID, heterosexual, PWID, MSM. So you have four groups. You can also assess what is those effects of those four groups on the outcome. So Cox is very flexible on the type of the predictors that you can put in the model. It can also be useful to adjust for the confounders. You can also include the interaction terms here. You can also predict the prognosis for the outcome, so you can have a prediction model there. It's also very useful for when you have a case-based surveillance, so you can follow cases over time in the surveillance data, connect those data, and then see how the survival or outcomes looks like in the public health space and using the surveillance data. So it's very applicable to the surveillance of cases over time when you collected the data at different points. But the survival analysis could be a little bit more complex. So when you have these things here, if you have a time varying covariates, if you have a cluster data, if you have a censoring that is interval censoring, if you have a competing risk. So these things are categorized as an advanced survival analysis. And today we're going to talk about the time varying covariates. So let's talk about What is a time-varying covariance? So the traditional Cox hazard, which is the proportional hazard, assume that the covariates in the model are time independent. What does it mean? Their value is fixed throughout the study. From the time they become at risk, they get to your study, to the time, all the way through the study, when they finish with the outcome or they censored, their value for the predictor or the covariate is fixed. Another thing about that one, the hazard ratio over time are fixed. So the effect of the covariates over time doesn't change. If you have those things, that's good. So you can use the traditional Cox proportional hazard. So you can also see it here in this form of the Cox. What we have in this model is the hazard, is the Cox model, and we are predicting the hazard of the outcome depending on the predictors X in the model. And what we have, there are two sections in the hazard function. One is the baseline hazard, which is depend on what time you're looking at the data. And there's an effect for the predictors, X. It could be, for example, gender. So there is no time in this part of formula, but there is a time at the baseline hazard. So what we are doing here, we are saying the baseline hazard could change over time, but the effect of gender on this hazard proportionally looking at the men versus women is always the same and it's constant because there is no time to it. There is no time associated with the beta, which is the effect of gender in your hazard model. So that is a big assumption. And when it exists, it makes everything simple. So when somebody asks about what is the effect of gender for AIDS survival, you're not going to ask about what time you're talking about. Is it the 6 months after AIDS? Is it the 1 year after AIDS? Or is it 10 years after years? The effect of gender on the survival is fixed and it's one value over time. This is what proportional hazard means. If the proportional hazard doesn't um, like it's not it's not there, so then you need to do something with it. Extended Cox model are required. So when we don't have that proportional hazard assumption, the hazards cross over time, the effect of predictors change over time, the predictor's value of change over time. So all of those things happen. There are three ways that you can check this assumption that the proportional hazard is enough. You can look at the graphical assessments to see if the hazard shape over time is constant. You can also check with the goodness of the fit if assuming a proportional hazard versus not assuming a proportional hazard is a good thing. So we have also p-values to report to that one. So there's a test to report if the proportional hazard is a good thing or it's a bad idea. We can also use the time-dependent covariates adding to the model to see if adding them to the model is improved the prediction for the model. So these are three ways to assess if that proportional hazard assumption is exist or is violated. So one of those approach that I said, you can use this model to assess if the proportional hazard exists for predictor X for now. So basically, you're going to use an extended covariate. You're going to say, I'm going to include an interaction between my predictors and a function of a time. So a function of the time could be anything, like time, follow-up time, times, for example, gender, or it could be a log of the time times gender. So you're going to add an interaction to your model, and then you're going to test if the coefficient for the interaction is equal to 0 or it's not equal to 0. So you can use the likelihood ratio test or you can use the wall test in the model to see if that term in the model hazard ratio has a significant predictors coefficient or not, and then you can decide. The important thing I want to highlight here, the type of how the function that you use to include t in the model is important. So if you, for example, you make a log of the follow-up time and then multiply it to the gender as a predictor in your formula, it would be different when you're looking only the t as a follow-up time or any other functions of the time. It will affect the test here. Let's go back to this idea of talking about more about what is a time-dependent variable. So time-dependent variable in this analysis would be any variable whose value change over time or any variable whose effect on survival change over time. So both of them are time-dependent variables, and they can be assessed by using the extended Cox model here. This is the form of the extended Cox model that assess the time-dependent or time-varying covariates here. You can see it's the same function. So we have a baseline hazard. We have the main effect of the covariates on the hazard. It's presented by the beta 1, beta 2, beta 2, which is the coefficient of those. And then we have also the interaction term with those effects in the model. So now we also adding the t, which is the survival time, to this part of the hazard model. And that's become an extended Cox model here. So time affect your baseline hazard and also added a coefficient to the model because the effect of the variable is changing over time. I think with an example that I'm going to bring up, it's become more clear what I mean. The time also added here to this part of the model. So these are three types of time-dependent variables. These are helpful sometimes to understand what kind of variables we need to model and how. So a time-dependent variable could be a define, could be an internal, or could be an ancillary type. So what is a defined variable? So let's looking at this table. The defined variable is when the policy change, when the system change, for example, or when the calendar time change. It's not because the behavior or something or a marker in the patients, because the system now decided to give, for example, ART to everyone. Before, it was like you have to go and then check the CD4 counts, and then if you're below, for example, 400 counts, then I will give you ART. But if the policy change, test and treat everyone, then from this month, they will receive ART regardless of the CD4. So if the policy change over time, if you want to assess the effect of the policy on this outcomes because of the treatment change in policy, then you're going to say, look, this is a defined. Everyone from this point, they have a different exposure. So you're going to have a defined time varying dependent variables. You're going to do this analysis. The type of data you need is a start and stop for the data. So you split your data for the policy change, before policy change, and after policy change. You can also have the internal time-dependent variable. So this is when people, for example, they didn't smoke and then they started smoking, for example. Or their CD4 count was not below and then their CD4 count is high. Or they had measured the blood pressure, it was low, now this is high. Their obesity status has changed over time. So you can see because of something happened to the patients or their choice, their exposure level changed. So we call it internal time-dependent variables. Here we also need a long format for each patient. During the changes for CD4 from visit 1 to visit 2, we need the start and stop time data frame. The ancillary data is interesting when your baseline hazard is changed. So for example, you can have you have a different hazard function for men and women, and then you want to model your survival according to different baseline hazard. This is sometimes also helpful when you have a time varying covariates. You're going to stratify your baseline hazard. So the baseline hazard will change according to the ancillary um, type of um, type of variable. This is good if we go now talk about this two examples. The concept that I've introduced, I think it would be more useful and meaningful if we're looking at an example. So this would help to talk about those concepts now. So this is the data from Australia. This is a study of um, I think 230 something participants. This is a methadone treatment clinic. So these are participants in two clinics. This is the day of follow-up since the people drop out from the service. And these two clinics had two different policy for methadone treatment. The database include the ID of the patient, clinic 0, clinic 1. The survival time is the day since people drop out from the methadone program or if they stay. So if they get 1 at any time, that means the patient drop out from the methadone program. The survival time is in days. We also had data from if they had any history of the prison or not. And they also, the methadone dose per day, it can goes from 1 milligram per day to 110 milligram per day. So different people, at the time they started the methadone program, they prescribed different dose of methadone, and they will stick to that one throughout the program. If you run a Cox model, this is a Stata, so this is ST Cox. The first predictor is the any history of being in prison, the clinic 0, 1, and this is the dose. And then you're asking Stata to present your coefficient. So you're saying do not present hazard ratio, present the coefficient. So this means like no hazard ratio. This is the option. This is what you get. You have a coefficient, which is for prison, which is another coefficient for clinic, and there's an effect for those. This is the form of the hazard you're going to write down. So baseline hazard, the exponential of the coefficient for prison minus the coefficient for clinic, and so on. And if you want to report the hazard ratio for the prison, you're going to make an exponential of the coefficient for prison. You get 1.39. And that means people with any history of being a prison, they have 39% more higher hazard for dropout from the methadone program versus those didn't have any history of being in a prison. So basically it means people with a history, they have a higher risk to be dropped out from the methadone program. How about clinic? People who receive the methadone program from clinic 1, they have only 0.36 as a hazard ratio. So that means they have 64% lower hazard to drop out from the methadone program versus clinic 0, which is good. So that means dropout is much lower in clinic 1 versus clinic 0. For the dose, because dose is a continuous exposure, is telling us for 1 milligram increase in dose per day, the hazard for dropping out from the methadone program goes down by 4%. So if you give them more methadone, it's less likely that they will drop out from the methadone program. Those things that I presented here, you can also directly ask Stata to give you this ST Cox, and you don't use that no hazard ratio here. The p-value is also present. Okay. But also, I can also looking at, I want to check some assumptions. So the model that I used was proportional hazard assumption. So now I want to check if the proportional hazard assumption is a good thing. I can use a test, and I can using the proportional hazard test, I can see for the prison, the p-value is not significant, that means it's okay. According to the Prism, there is no, the hazard ratio is fixed over time. I look at the clinic, I see the p-value is very small, and it is suggesting for the clinic, the hazard ratio proportional is not proportional over time. So that is a big issue here. We can't use the proportion hazard cox here. For the dose, it is okay. You can also look at the survival function output, and you can see over time the differences between the hazard, the survival in clinic 1 and clinic 2, they are not proportionally changed. This is year 1 mark. So before year 1, they are somehow close. After year 1, they are different, and they are not going to stay proportionally, right? So what we can do here, maybe one idea could be, can I report two hazard ratio, one for 1 year after the intervention, and then what is the hazard ratio for the clinics after the 1 year? So let's do that one. Let's see how the results looks like. So now I'm going to use this extended Cox model, and I'm going to say I have prison, dose, and clinic in my model, and then I have a time more than 365 days here, and I'm going to report two coefficients for clinic. One is the main effect, and the other one is a time varying effect. And now this is going to be my hazard function. There are two coefficients for clinic. One is the main effect, one is the time effect. And my time is divided by less than 1 year and more than 1 year. So if someone asks you, what is the effect of clinic on dropping out from the methadone program in less than 365 days, you're only looking at this effect. What is the coefficient, exponential of this coefficient? So the hazard ratio for 1 year follow-up is 0.63. If they're saying, what is the hazard ratio for more than 360 days? So you're looking at main effect plus the time varying effect. So here's the one, minus 0.46 from here, plus the minus 1.37, the exponential of that one. So after 1 year of the methadone program, clinic 1 is doing much, much better than the clinic 2. So there is a time dependent effect for the effect of clinic. This is how extended Cox model is going to help us to report two hazard, one hazard ratio in the 1 year follow-up, and then one hazard ratio for 1 year and after the follow-up. We can also include the T as an interaction in the model. So this is also interesting. So there is a time times clinic, and we have two effects for the clinic. One is the main effect, one the interaction effect between clinic and time. And there is a coefficient here as well. So there is a main effect coefficient, and there's a time interaction with clinic efficient. So what is the model is here now? If someone is asking you, what is the effect of clinic in 3 months follow-up? So 3 months is almost 91 days. You're going to put 91 days here in T, 91 times this effect for the time and clinic, plus the main effect. So your hazard ratio at 3 months is 6.3. What does that mean? It means like almost 600 times clinic 1 drop out at 3 months is more than clinic 0. But the effect is going to be interesting. At 6 months, the dropout from clinic 1 is only 2.5 times higher than the clinic 0. At 9 months, they are the same. At 12 months, clinic 1 is getting better at dropout versus clinic 0. At 24 months, clinic 1 is much, much better at maintaining people in the methadone program versus clinic 0. So this is What does it mean? It means like the effect of clinic one, whatever they give as a metronome program, it's affecting how long they stay, and it really depends on how long they stay in the program. That's why we cannot report only one hazard ratio. It's not fixed over time. We need to talk about the time here because there is an interaction here, and that is significant. Let me jump to another study, which is very interesting. This is another study looking at survival time for the patients who receive um, the heart transplant in Stanford. So this is a time to follow-up measured by day. The follow-up could be up to the time the death reported or censored from the study. This is a small study, 130, 103 patients enrolled to the wait list for the heart transplant. 69 patients received the transplant, and then 34 patients didn't receive the transplant. So the database is here. So this is 10 patients in this database. You can see the patient number one, the year this person added to the wait list for the heart transplant was 1967, long time ago. At that time, the patient had 30 years old. This person eventually, during the follow-up, died. The time to death was 50 days. This person had no surgery, the coronary artery bypass surgery, so that is the variable 0. This person didn't receive a transplant because, finding the heart transplant, it's pretty tricky. There's a wait list. There's a lot of matching, and biomarkers should be matched. So it's not easy to find heart for everyone. So unfortunately, this person was followed for 50 days, didn't receive the transplant, and then died at that time. The second patient also followed for 6 days, didn't receive the transplant, and then died. The third patient, so on. What happened to the fourth patient? So the fourth patient was a 40 years old patient. This patient followed 39 days, and this patient received the transplant. And before receiving the transplant, this person was waiting for 36 days. So this is important. For patient 4, there was 36 days waiting and then receiving the transplant, and then this person followed 3 days after the transplant and died. So this is a different story. Some of the patients they received the transplant, some of them didn't receive the transplant, as you see in this data. So I was able to explain to you what is the data looks like for 10 of them in the database. So now I'm going to set this time. Let's say this is my survival time. I need to say what is my time for survival, what is the failure, is died or not, and this is the ID of the patient. And I also report to you what is the Kaplan-Meier here survival. People who received the transplant, people who didn't receive the transplant during the follow-up. What do you see here? What is this telling you? The heart transplant, is it good for survival or is it bad for survival? Looks like it's good. There is a good effect. So people who receive transplant, they survive at a longer time because the survival is higher than those who didn't receive the transplant. So basically, it's suggesting that heart transplant is effective intervention to reduce the mortality here. I can also looking at the Cox model, hazard proportion model, and this is the coefficient. And then I can also report the coefficient to change it to the hazard ratio. And the hazard ratio is 0.27. The confidence interval is also not reaching to 1. So again, with the hazard ratio, with the proportion hazard Cox model, you can also see the hazard ratio suggesting heart transplant is a good idea, is improving the survival. So is there any problem with this analysis or this finding? there is a problem with this analysis, and I can show you what is the problem. So this is what happened. We call it a bias, right? Uh, People, there is an immortal time bias. So if you are in a wait list for heart transplant, you can only get heart transplant if you leave long enough to the time that there is a heart for you and you get the surgery and you receive transplant. So people who received the transplant in this study, the heart transplant, they had additional like survival because they had to be survived to get to the point to receive the transplant. So adding this wait time for those people who receive the transplant to the total survival time, it caused this bias to the study. And we call it immortal time bias, right? So this study was different from the time that you randomize people, and then on day one, people receive the heart transplant or people who don't receive the transplant. This is different. This study has a waiting time, and people who receive transplant, they had to survive up to the time to the transplant to get to this transplant. So we call it immortal time bias. And we want to, why this is happening? Because there is a time dependent exposure here. So let me go back to the data, and now we want to fix the data. So now I want to split my data into two things. For people who receive the transplant, there are two time periods. They have time that during that they didn't receive the transplant, and they also have follow-up time at the time they received the transplant. So I'm going to split my data into those times for each patient who received the transplant. So let's look at patient number 4 here. Patient number 4 received the transplant, right? But this person had 36 days before receiving the transplant. So I'm saying the transplant is 0, post-transplant is 0. And this person had 3 days after transplant, and then this person died. So what I'm going to do, I'm going to split this data for each person to say exactly what is the exposure time means here. And then if I split that data, then I'm going to have 172 observation. 34 of them are before the transplant. 138 of them are after the transplant. And this data is coming from 103 patients. So now I'm going to run a Cox model here. And now I have an exposure which is 0 or 1. If they receive the transplant, is going to have to be post-transplant 1. If they didn't receive the transplant, it would be 0. Now I'm going to report the hazard ratio here. The hazard ratio for the time that they are receiving the transplant versus the time they didn't receive transplant is 0.98. The confidence interval is 0.5 to 1.8. The p-value is not significant. So what is the conclusion here? Now, because I included a right analysis here, what is my conclusion? People who receive transplant post-transplant have only 2% lower hazard for death compared to the pre-transplant. And that suggesting at that time, doing a heart transplant was not improving the survival of the patients. That is totally different from the analysis that I reported had a bias. So this is very important. If the exposure have changed over time or people have a wait time to exposure, you should be careful about that exposure because it's changing over time and it's not good. It's a bias if you assume that's a fixed effect, and you should not include it as a fixed effect in your study. I want to also show you the results in R is the same. So when I look at the clinic data in the methadone study, I also was able to produce the Kaplan-Meier survivals by clinic. This is also the Cox proportional hazard for the clinic effect. You can see the clinic was reducing the hazard for dropping out, clinic 1 versus 0, by about 64%. So the same thing. I wanted to wrap up here. All the analysis and all the output slides are in this link. I will put it again in the chat. And I wanted to stop here for any discussion or any question that we have, and I will end with a consultation link that I will provide if you have any follow-up question. We can meet again in a one-to-one setting. So thanks again. I'm looking at the questions and or any comments here. Let me stop sharing and so I can see the screen a bit. All right. And I want also to put again the link in the chat. And let me know if there is any question, but I'm happy to share more examples of this time varying covariance. So I know you're working on a lot of HIV data here, right? So if you follow patients over time, from the time of diagnosis to the time people receive the treatment, there are some times here, right? People may not link to the treatment, or they hesitate to start, or the strategy or the policy is not giving them treatment right away. I know it has changed, but it wasn't changed a long time ago. So in 2017, I think the Vietnam started to test and treat. So if you want to compare the survival of the patients who diagnosed with HIV from the time of their diagnosis, exposure to ART is change, right? Exposure to ART has a time lag. Before 2017, because of the program policy, it's an external variable. They couldn't get to the treatment. So for them, if you're comparing test and treat versus the non-test and treat, then those who get to the test and treat moment, they had a benefit. They had to survive to that time to get to the treatment. So there's already an immortal bias in your analysis. What you should do here, you should split this time before ART test and treat strategy, time after test and treat strategy, and then you should look at the outcome. So this is one example I want to share in HIV. It's very the same problem that we look at the heart study data. We will have the recording yes, we will put the recording in the same link in the GitHub, so you should be able to download and watch it. You should be able also to do this data analysis and the R analysis, getting the same results from my slides, so you can explore how the data looks like, how the output looks like. Is there any example you want to talk about? Is there any comments that you want to talk about? And I want also to share two things here on my slides. I'm happy to follow up on the questions as well. Let me share again my screen. So if you have any data analysis question or any survival talk follow-up, I would be very happy to meet with you in this Zoom space. So it's going to be half an hour. You can go to this link or scan the barcode to schedule a meeting with me. And then we can definitely go through the details and then what is your need for your data analysis. And if you're interested to join more training talks for next week and the week after, we are going to talk about how would you select your predictors for a model. And then the week after, we're going to talk about how you present data visualize your data using R, a great platform to visualize data. So these are the next two trainings. Next week and the week after, we're going to talk at the same time. Great.